peripheral stenosis, do not respond to medication, or have repeat surgeries. Those cases are reserved for pedicle screw rod fixation. So then the question arose, should we do more than only fixating the spine? And that question arose because of also, again, from findings in the human field where they perform distraction to preserve the lumbosacral foramen. And that is shown here. So in those days, we already were working with the cervical spine, with the washer. You can see here the washer. And with the SYN cage being used in the cervical spondylomyelopathy cases. And then, of course, the question arose, can we also use this cage in our low back patients? And why should we do that? Well, there are two reasons for that. First, to preserve the foramen, and second, to promote fusion between S1 and L7. Since we should not rely on implants for the remainder of the dog's life. So preservation of the foramen is important because the inflammation also affects the root when it exits the foramen in humans, but we also know that that is the case in dogs. And actually foraminal stenosis has got a lot of attention in the recent years in the veterinary literature. So usually by findings of thickening of the nerve root and focal neuritis, and also by the techniques that describe opening this foramen by foraminotomies. So the cage allows restoration of disc height and thereby preservation of this foramen. And this is shown nicely in this image, where you can see the pre-operative radiograph, and this is after distraction. So with distraction, you open also the foramen. You not only restore disc height, but also open the foramen. However, if we look at this fixation, it is not really a stable fixation, considering the foramen. So there will be a lot of tension on these screws when you distract this junction. And it is biomechanically far more stable to put something in between the vertebra, and by that way you have a very stable situation. This is a dog that underwent distraction. So, and I just want to finish this talk with a little bit on the distraction and spinal fusion. And if you talk about that, you really need to look also in the literature and in the history of spinal fusion. And this guy did a lot of work on that in humans. He was an American neurosurgeon that also had some heroic findings in literature that in the connection with the Pearl Harbor attack, he performed 44 craniotomies in 4 days. So that was a busy period for him. But he is mostly renowned for his contribution to spinal neurosurgery, where he more or less developed the procedure that is now very common in humans. It is more or less standard of care in spine surgery in humans, and that is the fusion of the low back by PLIF and the fusion of the cervical vertebra by the anterior cervical interbody fusion. and it's also known as the Cloward procedure by his name. So he developed that in the 50s, 60s of the last century, and this was followed by many modifications. And at the same time, this also gave an enormous stimulation for companies to develop all types of cages and implants to stimulate this spinal fusion. So nowadays, if you look at the human spine fusion field, which is standard of care in spine surgery, you find these types of procedures: the PLIF, the A-LIF, the T-LIF, the X-LIF, and these are all modifications, but they all want to reach the same principle, and that is fusion of two vertebrae. PLIF is by the posterior root, and A-LIF is by the anterior route. T-LIF is by the transforaminal route, and we also have a route going from the lateral side. And then in the cervical spine, it is either done from the anterior side or from the posterior side. So how does this procedure work? From the anterior direction, the idea is to put something in between the vertebra. By that way, distract the vertebra, restore disc height, and this device that is put in there that should stimulate the spinal fusion across that spinal unit. And it's done in open approaches, it's done in minimal invasive approaches, it is done with CT guidance, even with robotic guidance nowadays. This is the transforaminal route. It is working more on the side of the spine, and then working through this pedicle, these cages are then inserted, banana cages that are inserted into the disc space. Here you can see the minimal invasive route using also with endoscopy. This is nowadays has been introduced into this field. This is the direct lateral approach. That is also a minimal invasive approach to the human disc, and via this approach, these cages are put in. So this was being developed in the human field with cages that are titanium, PEEK. I've told you about that. Either instrumented, so protected with pedicle screws, or not instrumented, standalone cages that also may include some screws. And then this also entered the veterinary field. So if we look at the veterinary literature, and we look at cages that are used for the lumbosacral area, we may find some literature on that. And this is the Spondylofitsbolt that has been developed by Noel Fitzpatrick in the UK. Here we see the Fitsbolt sitting there. And in this image, he still stabilized this whole structure with pins and screws. But later on, he went also to pedicle screws. Also here, the insertion points are defined for the pins and the screws, just like in our publication. And this is the modern version of the Fitsbolt. So you can see here the Fitsbolt in place, which is even stabilized with a TTA screw here. And then over this bolt, the pedicle screws are placed. Pedicle screws with rods, all produced by himself, by his company. Not easy to get access to this material. So what else is there on the market? There are some companies producing implants for the veterinary market, This is an American company, Artemetics, which is making this system, the Arcus polyaxial pedicle screw and rod system. Looks very nice, and the polyaxial system means that the head is turnable in comparison to the screw shaft. And this is a big advantage, because if you put in your pedicle screw and it has a static head, then you have to adapt your bar to the screws. So you may have to bend your bar, but not with this system. If the head is movable, it doesn't really matter how you put in. No, I'm not saying it in the right way. The screw can be a little bit off center, and you just turn the head towards the bar, so the bar can be kept straight, and the heads are adjusted to where you find the room to put the bar. And as soon as you then insert this little nut inside, the bar will be fixed to the head, and the head will be fixed to the shaft. So the whole system becomes immediately stable. So that's a big advantage. And nowadays, for humans, everything is polyaxial. So you don't find any static pedicle screws anymore. Most of the pedicle screws are polyaxial, because it makes it quite more easy for the surgeon. So I found that system. So this can be used for the veterinary market. And this is another system. This is developed by a Thai company that put out this screw and rod fixation system for dogs and cats. Actually, there are multiple sizes in this pedicle screw, and that can be used for smaller dogs also. And we contributed with the biomechanical study for this system, and this just shows you that we compared in the lab this system versus PMMA bridges, and this system was biomechanically a lot more stable than the PMMA, which is the sort of routine standard of care in veterinary medicine. So just to finish off, where are we now in Utrecht with this development? Well, we did a biomechanical study in canine cadaver spines, looking at the standalone cage, the SIN cage for the low back, and protecting it with our pedicle screw and rod system. And we found that if we destabilize the spine with a discectomy, that we can nicely stabilize it with a standalone cage, and that of course the pedicle screw system adds to that stabilization, but there are not a lot of differences between cage alone and with the pedicle screw and rod system, especially not in this kind. So this led us to the conclusion that we may try to use even standalone cages for the low back in dogs. And at this moment we have an ongoing study in dog patients with severe degenerative lumbosacral stenosis, comparing the outcome in dogs that were treated with only a standalone cage and dogs that were treated with cage and pedicle screws. And hopefully we can conclude that series this year, maybe next year, and then report on that. But that was, I think, well, there's a summary still. This is the last slide for today. And in summary, I think there is a role for distraction, especially in dogs with foraminal stenosis, in degenerative lumbosacral stenosis. You can distract with spinal cages. When you distract, the ultimate goal is spinal fusion, because we cannot rely on these implants for the remainder of the dog's life. And instrumentation can protect the cage. And so if you start doing this, maybe it's wise to use instrumentation and not rely only on the cage itself. However, the downside of all this is that the implants are not routinely available to veterinary surgeons. There are only 1 or 2 companies out there making it for the veterinary market, and other than that, you either have to develop it yourself, or you have to go to the human market, and that is of course very expensive. But I'm sure that in the future, there will be newer implants available for us veterinarians to use in our canine patients. With that, I think we should end this day, but there may be still some room for questions. Yeah.
Спасибо большое за лекции. Скажите, пожалуйста, а как часто вы прибегаете в своей практике к фораменэктомии при пояснично-крестцовом стенозе, и какой критерий, с вашей точки зрения, для прибегания к этой методе?
Okay. That's a good question. So in our practice, we don't routinely do foraminectomies. What we do is, if we see foraminal stenosis on the MRI, then we go for a distraction with a cage, either standalone or in combination with pedicle screws. So I don't do only foraminectomies. I always do a dorsal laminectomy. I try, if I don't do a stabilization, I try to at least enlarge the entrance of the foramen. But by dorsal laminectomy, you cannot reach the middle or the exit zone. If I really know that I want to enlarge the foramen, restore it, then I advise a distraction with a cage.
Спасибо, я поняла. И второй вопрос. Вы говорили о том, что вы рутинно берете бокпосевы, когда вы делаете фенестрацию диска. Какую флору вы обычно оттуда получаете?
Okay, that's about the question about the culture. So what type of bacteria do we find? We find primarily Staphylococcus, Aureus, Pseudointermedius, sometimes E. coli, but it's quite rare. Sometimes other strange bacteria, but those are the main bacteria that are cultured in this 15%. Propionic is another bacterium that is found. Yeah.
Спасибо, да.
Okay.
Технический вопрос. Когда вы используете транспедикулярную фиксацию, располагаете вы пациента с спиной в состоянии легкой флексии, в нормальном положении или легкой экстензии?
The position of the patient for a pedicle screw is that the dog is in ventral recumbency, so it's on the stomach, abdomen, with the hind limbs in a neutral position, so not flexed cranially, also not extended, but in a neutral position, right in the middle. There was a slide in my previous lecture. That was actually the position that we put the dog in. So if you look at from the side to the limb, the stifle joint is in flexion and the hock joint is also in flexion. Hip, stifle, hock, toes. Not extended to the hind, not flexed forward. Is it clear?
Да. Второй технический вопрос. Вы достигаете фузии позвонков только за счет того, что дожидаетесь, когда произойдет спондилодез вентральный, или, может быть, еще делаете артродез путем, допустим, травмирования суставных отростков позвонков.
Yeah. So for the spinal fusion to take place, so what you do is you do a discectomy. You take out the disc, all the disc material, meaning the annulus, dorsal annulus, the nucleus, pulposus, and then I go in. I distract the space, and I go in with a scraper, and then scrape the end plates. Only scrape the cartilage from the end plates, not the bone itself. I do not go in with a burr, so I do not damage the bone part of the end plate, but only the cartilage. Take away the cartilage of the end plate, and then usually it's not easy to see, but until it starts to bleed a little bit, but preserve the bone end plate, and then put in the cage. Because the cage, it's in distraction, so if you put in the cage and then take away the distraction, the bone will collapse on the cage, and you get a fair amount of pressure. If you take away the bone, then the cage will collapse into the vertebra. Not immediately, but in the weeks, months after that. That's called subsidence. And we don't want subsidence, because if you get subsidence again, the foramen will close again. If you get subsidence on the cage, the foramen will also become smaller. So the cage should keep the bones, the vertebrae, from each other in the position for the spinal fusion to take place. And this will take about 6 weeks to 3 months. So in that period, the bones should be kept from each other, then spinal fusion occurs, and then your foramen is preserved. It cannot become narrow again.
Спасибо, очень подробный ответ, но, в общем, можно сделать вывод, что если вы не упоминали про дорсальную фузию, повторить. Но так как Бьорн ничего не сказал про дорсальную фузию за счет артродеза суставных отростков, видимо, он ее не делает. Я сделал такой вывод. И третий технический вопрос, он тоже касается бак-посева. Всегда ли при фенестрации диска, он упоминал про люмбосакральный диск, хотелось бы узнать, при фенестрации, допустим, грудопоясничного отделения позвоночника, делают ли посевы, и если да, то какие результаты получают?
Okay, sorry about the first question that I mistook. So the answer is no. I do not do arthrodesis on the dorsal side. I do not put their cancellous bone. It has been published by, I think, a group from Germany or Switzerland, or Slogan also did that in the past, dorsal arthrodesis. Yeah, I don't have really an answer why I don't do it. We went for intervertebral fusion, which seems for me more logical as from a biomechanical standpoint. So that was the first question. Then the second question was the bacteria. No, we don't routinely culture from thoracic or cervical spine, only from the lumbosacral spine, because there is this is a clear focus point also in the human literature, that in the low back discs, bacteria are found. But I do not culture in dachshunds or in cervical wobblers. That I do not culture, unless we have an indication of on imaging of discus spondylitis. And then there was another question. No? Okay. That's it.
Можно уже говорить? Такой вопрос. Вносите ли губчатую кость вокруг кейджа, так же, как и в шейном отделе?
Yes, yeah. The answer is yes. I do use bone grafts, but so because we always do a dorsal laminectomy in the lumbosacral area, then you have the spinous process of L7 and the spinous process of S1. I take that away, so I keep that as a bone graft. Then I start the burring for the dorsal laminectomy, and with the burring, you get this bone debris in the surgical area. We do burring with flushing, and you get this very nice bone debris. So I make sure that my assistant doesn't suction it away. So we keep that in the surgical area. Then I collect that, and this is actually very nice to put in the cage. So this debris of bone that is produced by the burring, I use that to fill the cage. And then the spinous process can be chipped in little pieces, and you can use this to put them around the facets, for instance. I don't routinely do that, but you could do that. I do not go to a separate site for a cancellous bone graft, like iliac wing. I don't do that, because there's a lot of bone already in the procedure itself.
И второй вопрос, может быть, банальный. Насколько большую нужно давать дистракцию, как подобрать размер кейджа? Вот ведь нужно их побольше туда заколотить.
Yeah, that's a very good question. How far should you distract? I distract up to 5 millimeters because the cage that I use is 4.5 millimeters wide. So I need at least 5 to get it in a normal, in a position. And how did I come to that? Because I measured on CT scans and MRI scans the normal width of the lumbosacral disc space in dog breeds, about 30 kilogram retriever, German Shepherd. If you look at the normal width of the disc space, it is usually 4 to 5 to 6 millimeters. That's the only reason, but it is, yeah. Maybe if I had a cage of 2 millimeters, it would also work, but I don't have it.
Можно, да? А скажите, пожалуйста, а вы используете кейджи, потому что появились какие-то осложнения в виде потери позиции? Это первый вопрос. И второй сразу. Не замечали ли вы, что очень часто через какое-то время происходит потеря репозиции в виде коллапса межпозвонкового промежутка, при этом клиническая картина у животных не проявляется? И с чем, возможно, вы это связываете?
Yeah, no, that's a very good remark. We see loss of disc height in the whole process of disc degeneration, and especially with degenerative lumbosacral stenosis. That's one of the hallmarks of the disease, that your disc is bulging and you lose disc height. If you follow this over time, and of course in dogs that are treated conservatively for maybe a year, come back after a year, have again pain, we repeat MRI or CT or radiographs, we can see that this disc height becomes smaller and smaller. So this is progressing over time. then if you treat your dogs with dorsal laminectomy and discectomy, if you take away the disc, and you see those dogs back in 1 year time for another reason or for the same reason, and you do repeat imaging, you see the disc height also collapses. So, thinking about that, distraction and preserving disc height and your foramen is not so illogical. It is one of the things that is one of the primary aims for human spine surgery. It's all aimed at preserving disc height and preserving your foramen, because that will lead to long-term success for the patient. And not relying on implants, but relying on spinal fusion. And the other option would be a functional restoration of your disc, and then you talk about disc replacement. And nowadays there's a big discussion in human spine field: should we fuse or should we replace the disc? Fusion has such good success in humans that it's very difficult to well, at least when I go to a human spine congress, there's always discussion: fuse or disc replacement. And fusion already has such a gold standard in human spine surgery that the people that put in artificial discs have a big problem trying to beat the success of fusion. In veterinary medicine, we only have one disc replacement device, that's the Adamo disc, and there's not a lot of published on that yet. So that still needs to find its way to the literature.
Еще раз, вопрос не совсем в этом был. Речь только про транспедикулярные фиксаторы. Вы начали использовать кейджи, потому что получили какое-то количество осложнений после транспедикулярных фиксаторов. И не замечали ли вы, что потеря репозиции происходит после, через полгода? Делаете контроль и видите потерю репозиции на транспедикулярном фиксаторе в виде коллапса межпозвонкового. И у животных при этом нету клинической картины. Только про фиксацию.